Hello, one more time in this ergonomics course. Here I am. You can see in the back of my little cottage by the lake. So I'm going to get started on chapter 15, ergonomics in the healthcare industry. And this will be the last time you'll see my smiling face in this class, more likely. So let's get to it. I know you're anxious to get this over with. All right. Started here, close all this garbage over here. And chapter 15, module 16, because we doubled up on 13 and 14. So here we go. Ergonomics in the healthcare industry. Objectives: identify causes of work-related musculoskeletal disorders. We know them as WMSDs. Identify within the healthcare industry. Identify key contributors to those WMSDs and solutions to reduce the potential work-related musculoskeletal disorders. The introduction to the healthcare industry is huge and growing. Nurses and nursing aides are two of the top 10 professions that suffer from WMSDs. If you look in the paper here from Fort Smith paper, and you want a job, if you're a truck driving nurse, you're going to have a job because there's always jobs in there for truck drivers and nurses. Well, most injuries result from repositioning, turning, and transferring patients, as well as pushing beds and gurneys. Long hours are common in the healthcare industry. WMSD is one of the leading contributors for lost workday injuries and illness cases. This is old information, but it still gives you an idea of the health and social assistance, manufacturing, and construction, that the OSHA rate, the incidence rate for 10,000 full-time employees. I think that's supposed to be 1,000, but it says 10,000. Is higher than it is for manufacturing or construction. So patient handling overview. Healthcare workers routinely use manual lifting techniques in life-threatening situations. I mean, in a life-threatening situation, you can't go wait for somebody to bring a gurney or bring something. So of course they do. Any type of manual lift puts forces on the spinal discs, shoulders, necks, and back of the lifters. We all know that. Assessing the risk in nursing homes is complex because they involve the repeated lifting and positioning of residents. In addition, such factors as resident dignity, safety, and medical contraindications must be considered. Now, you notice this segment is really going to focus on the healthcare industry, but nursing homes in particular, and that's because that's where most of this stuff happens. I mean, it happens in hospitals and all aspects of it, but it's more concentrated in a nursing home. The analysis of any patient lifting and repositioning involves an assessment of the needs and abilities of the resident involved. Here's some words to the wise. Don't drink and drive, because there are people out there who text and drive. And they'll hit you, and then it'll be your fault because you can't prove they were texting, but they can sure prove you were drinking. Patient handling overview. Again, assessment should include the examination of such factors as the level of assistance the resident requires. Not everybody's the same. The resident, they can help themselves a lot, needs a lot less help, obviously, than somebody that can't. The size and weight of the resident. Unfortunately, as we get older, we tend to put on weight. The ability and willingness of the resident to understand and cooperate. Some people, as they get age, they have a problem understanding what's going on, and they just don't want to cooperate. That happens. Any medical conditions that may influence the choice of methods for lifting and repositioning. Another nice thing about aging is you get more medical conditions too. Protecting workers in nursing homes. The number and severity of injuries resulting from the physical demands in nursing homes and associated costs can be substantially reduced. Providing an alternative to manual resident lifting is the primary goal. OSHA recommends that manual lifting of residents be minimized in all cases and eliminated when feasible. And that's a lofty goal. That's a really good thing to try to get to do. An effective process should be tailored to the characteristics of the particular nursing home, but OSHA generally recommends the following steps. Management support. Strong support by management creates creates the best opportunity for success. Management should create clear goals, assign responsibilities, provide resources, and ensure that assigned responsibilities are fulfilled. Management support is really basic through any endeavor in a company. Involve employees. Employees are a vital source of information about hazards where they work. And again, in any industry, and I've told you this many, many times, always get the employees involved if you can and talk to the employees. They know more about what's going on than anybody else. Their involvement adds problem-solving capabilities and hazard identification assistance, enhances worker motivation and job satisfaction, and leads to a greater acceptance when changes are made. They can submit suggestions or concerns. They can discuss the workplace and the work methods, participate in the design of work equipment, procedures, and training. They can evaluate equipment you're thinking about getting, respond to employee surveys, participate in task groups with responsibility for ergonomics, and they can participate in developing the home's ergonomic process. So you definitely want to get your employees involved. Identify problems. Again, back to this, can be attained from OSHA logs, workers' compensation loss runs, accident reports, which of course would be pretty similar to OSHA logs, insurance company reports, employee interviews or surveys, and workplace observations. And if you have like a nurse or something like that, they can help you out too. What are people complaining about when they come into the nurse's station? But OSHA logs, workers' comp loss runs are two of the biggest things and the most accurate too to get information from. Implement solutions. Select and implement suitable options to eliminate or reduce hazards. May involve use of equipment, training, and/or work practices. Address reports of injuries. Like many injuries and illnesses, early reports of WMSDs can limit the severity of injury, improve treatment, minimize likelihood of disability or permanent damage, and reduce costs. And again, I'll say it again, like I've said many times before too, is you can get people to report injuries and illnesses early. You could do something about it earlier. They're going to spend less time in pain, and it'll work out better for everybody. And if they report them, they're not going to go away. They're only going to get worse. You have to make that known to them that if they don't report them, they're not going to go away. So might as well go ahead and report it and get it taken care of. Provide training. Ergonomics training should be integrated into general training on job practices. Effective training covers the problems found in each employee's job. Evaluate ergonomic efforts. Evaluation and follow-up are central to continuous improvement and long-term success. Once solutions are implemented, make sure they're effective. You could say you're going to do something and number one, did it get done? And number two, if it did get done, did it do what it was supposed to do? Not always happens that way. Patient care ergonomic resource guide, safe patient handling and movement. The following flowcharts address relevant resident assessment factors and recommend solutions for resident lifting and repositioning problems. I like Pringles, but that's a little too steep for me, even $999.99 a can. I have to cut down to maybe one can a week if I had to spend that much money on one. All right, now here, I don't like the way this cuts the top of it off, but it's caregiver assistance. I ain't trying to get the top of this thing, I can't. Because this is up here. This is, I think, repositioning somebody. So it's, can the patient bear weight? And I'm gonna get off of this. All right, there we go. That makes it a little smarter to read, but we can see it anyhow. Transfer to and from bed to chair to toilet, chair to chair, or car to chair. First thing is, can patient bear weight? Fully can bear weight, then they probably not need any help. If they can partially bear weight, is the patient cooperative? If they are, you can use a stand and pivot technique. If they're not, you're going to have to use a full body sling and 2 caregivers if they're not cooperative. They cannot bear weight. And again, if they're cooperative, you can use a full body sling. If they can bear weight, and if they are cooperative, does the patient have upper extremity strength? If they do, seated transfer aid may use gait transfer belt until the patient is proficient in completed transfer. And if no, then you go back up to use full body sling and 2 caregivers. Lateral transfer to and from bed to stretcher or trolley. Can patient assist? Yes, caregiver assist not needed. Partially able to assist or not at all. If patient is less than 100 pounds, use a lateral sliding aid and 2 caregivers. If patient is 100 to 200 pounds, use a lateral sliding aid or a friction reducing device and 2 caregivers. If patient is over 200 pounds, use a lateral sling aid in 3 caregivers, or a friction reducing device or lateral transfer device and 2 caregivers, or a mechanical lateral transfer device. Transfer to and from chair to a stretcher. If the patient is not cooperative, you're going to have to use a full body sling lift and 2 or more caregivers. If they are cooperative, can they bear weight fully? Then you don't need any help. Partially, if exam table stretcher can be positioned to a lower level, use a non-powered stand assist aid. If not, use a full body sling lift. So if that stretcher can get down lower and they can get on it, then bring it back up, that would help a lot. If not, you're gonna have to use a full body sling and 2 or more caregivers. Repositioning in bed, side to side or up in bed. Again, can the patient assist fully? Probably don't need any help. If they can't at all, you got to go to the full body sling and 2 caregivers. So encourage patient to assist if it's partially, and then here's the 200 pounds. Pressure reducing device, at least three caregivers that are under 200 pounds. And that's over. And if they're under 200 pounds, a friction reducing device and 2 to 3 caregivers. Reposition in chair, wheelchair independency chair. Can they assist fully? They're not, caregivers not needed. Partially, if patient has upper extremity strength in both arms, have patient lift up while caregiver pushes knees to reposition. If patient lacks sensation, cues may be needed to remind patient to reposition. There's a chair recline chair, and use a friction reducing device and 2 caregivers. Is patient cooperative? Yes, use a full body sling or non-powered stand assist aid and 1 or 2 caregivers. And if they're not cooperative, you're going to have to use a full body sling and 2 or more caregivers. You can see where that's going. That's going to be the end up in every one of them, just about. Transfer a patient up from the floor. Was the patient injured? Yes. Okay, was the injury minor? Yes. Is patient, then you're going to go down here. They weren't injured. It was a minor injury. Is patient independent? If they're not, full body sling and 2 caregivers. If they are, caregiver assistance is not needed. Just stand by for safety as needed. Now, if they were injured and the injury was not minor, and then that depends on type of severity injury. So you have to follow the operating procedures there. Transfer from sitting to standing position. This is a powered sit to standing assist drive. You can see what that involves. I'm not going to read all this stuff here. That's for transfer from bed to a wheelchair. That helps the person get up. Resident lifting. Portable sling device, sling type can be a universal hammock sling or a band leg sling. You can see, but there, the issue there is you got to get the person into it. That's not always that easy. So they're off here. So when to use that, lifting residents who are totally dependent, are partial or non-weight bearing, are very heavy, or have other physical limitations. And this is just an ambulation assist device. This is for people, for patients that are ambulatory, which means what? If you're ambulatory, you can walk. So they can walk, but they need a little assistance, maybe just to keep from falling down, because that's one of the hazards of getting the golden years. Lateral transferring this position. This is just a friction device that makes this, you can slide, and it has handles on it. So you can pull that patient from one device to another because it has less friction and you have a good coupling with the handle. So that's pretty slick there. No pun intended. The other lateral transfer, this is a Jerry or cardiac chair to bed. And that's a chair that will lay down flat up to the height of the bed. It's the transfer of patient from the bed to the chair or vice versa. This is another type of Jerry or cardiac chair. When to use repositioning partial or non-weight bearing residents who are cooperative. You can see that's a big thing with patients. If they're cooperative, if they're not cooperative, you just have to kind of move them yourself because they probably aren't going to move. Lateral transfer in the sitting position is transfer boards, some with a movable seat. I can just swivel on this. Transfer from a sitting to standing position. My brother-in-law, who's about 5 years older than I am, and it's pretty heavy set. He has one of these at home, so he can sit down and get up from it pretty easily. That's transfer sitting position. Again, you put a belt around somebody that has handles on it. So again, there's your coupling coming in there again. You can grab that something, because part of the problem with a human being is, where do you grab them? It's hard to grab them. So that gives you handles. Electric power height adjustable bed. It's to reduce the help caregiver from bending and interacting with the resident. You can lift them up or down. Trapeze bar. Now, for that to happen, somebody has to have the ability to assist in some upper body strength, but they can help themselves up by grabbing that trapeze bar. Pelvic lifts, hip lifters. This is they sit on this and you inflate it, and that kind of helps them get up. Bathtub, shower, toileting facility. There's a shower that's on a portable. And remember, patients that are older still have to get bathed. And height adjustable shower gurney or lift bath cart with a waterproof top. Built-in or fixed bath lifts. They could be built into the bath and get more. Can be, that one doesn't look very sturdy, but can be portable. Shower and toileting chairs. Bath boards and transfer benches in the shower. Toilet seat risers, making the seat higher, and also aids around the toilet to get up and down. Bathtub, shower, and toileting activities. Grab bars are very helpful, and a lot of times showers and stuff have them now already, even before you're in a nursing home, and they're very helpful. So ergonomics in the healthcare industry, problems and solutions for other than resident lifting repositioning. Some reports indicated a significant number of work-related musculoskeletal disorders in nursing homes occur in activities other than resident lifting. Some examples: bending to make a bed or feed a patient, remove items from a deep cart, or manually cranking an adjustable bed. I think those have improved dramatically over the years. So, lifting food trays above shoulder level or below knee level, collecting waste, pushing heavy carts, lifting and carrying when receiving and stockpiling supplies, removing laundry from washing machines and dryers, pushing heavy carts. They have come a long way with carts too, bigger wheels, just easier to push. For other than resident lifting, again, these tasks may not present problems in all circumstances. Consider duration, frequency, magnitude, and awkward posture of the exposure. Following slides are examples of some possible solutions for activities other than resident lifting and positioning. Let's go back to full screen here. Well, I guess I went back to full screen too quick. Okay. Use of carts. This is a variety of carts. Removing food trays, cleaning supplies, equipment maintenance tools, dispensing medications. Carts, you'll see a lot of carts in hospitals and nursing homes, and they're great all over the place. I mean, any industry, anything you put on a cart, move, and it weighs anything, it's probably going to weigh better. Can't put it in your pocket. Mobile medical equipment, work methods and tools to transport equipment, oxygen tank, and what you call that, the feed bag of sorts, saline solution bag. Liquids in housekeeping. There's a good example. You fill that up with a hose, and then you empty it into a drain with the valve on it there, and you don't have to pick it up or move it. And water's heavy. Water weighs about 9 pounds a gallon. So somewhere around there, 8.5 or 9. So you got 5 gallons of water. It's pretty heavy. So that's a great way to do it. You can fill that to the top for water for washing or mopping. Filling empty liquids in containers, again, in kitchens, in dietary, when pouring soups or other liquids that are heavy. Points to remember: reduces risk of spills and burns. You use a ladle or some other means. You don't want to lift that whole vat of liquids, whatever it might be, soup, and frequently they're hot too. So you certainly want to lift them hot. Hand tools, again, this is just the same as general industry here, pretty much. A hand tool, you can see that hand tool, the bent handle, keeps that wrist straight. Linen carts, spring-loaded carts that automatically bring linen within easy reach. You put more stuff you put in there, the springs go down. And as you take stuff out, they come up and bring that stuff up, because reaching down to one of those bottom carts is not really ergonomically correct. It's not very good at all. Again, you do it once or twice a week, and probably not a big deal. If you're doing it every day, all day, it is a big deal. Handling bags, most of the time is trash. And again, same principles there, but here you're gonna have to take it off of there and put another bag on there. So you want to have it at the right height. Reaching into a sink, tools used to modify a deep sink for cleaning small objects. You can see what they've done here. They've taken like a dish pan or a dish, what do you call it, turn it upside down to make it easier to reach into this deep sink. And that's pretty smart. I'm the designated dishwasher at our house, and we have a double stainless steel sink. It's double, and in the middle of it, and of course, there's a spacer there. So what I've taken to do is to lay a washcloth over it to give it some coupling, so to speak, and some cushion the impact. And I'm washing like a glass or something on it, instead of it's down in the sink, I just put it up on there and use that to wash around it, or whatever I have to wash to set it on, rather than have to reach down into the sink. And I wash dishes a lot, so it helps. Loading and unloading laundry, front loading washers and dryers help. I do the laundry too, but that's not that big a deal. We have a front loader washer. I mean, a front load dryer and a top load washer, but in a place like a hospital or a nursing home where you're doing a lot of laundry, it can make a significant difference. Cleaning rooms, wet method. Okay, again, there is kind of the same thing. You have a hose to fill this up, and it's the faucet to empty it. And then, of course, if all else fails, you can always resort to the old whiskey vending machine. All right, they're probably not one of those in the hospital you go to. Cleaning rooms, electrical work methods and tools to vacuum and buff floors. So the vacuums and buffers, they're make sure they should be lightweight, adjustable handles, triggers, long enough to accommodate at least the index and middle fingers, easy to reach controls. So there's a lot of things. Buffers are kind of hard to steer sometimes if you don't know what you're doing. Got to have training on buffers too. Training is critical for employers and employees to safely use the solutions identified in these guidelines. Of course, training should be provided in a manner and language that all employees can understand. The following describes areas of training for nursing home employees, their supervisors and program managers who are responsible for planning and managing the nursing home's ergonomic efforts. OSHA recommends refresher training be provided as needed to reinforce initial training and to address new developments in the workplace. Nursing assistants and other workers at risk of injury, employees should be trained before they lift, reposition residents, or perform other work that may involve risk of injury. Ergonomics training can be included with other safety and health training or incorporated into general instructions provided to employees. Training is usually most effective when it includes case studies or demonstrations based on the nursing home's policies and allows enough time to answer any questions that may arise. Training should ensure that these workers understand policies and procedures that should be followed to avoid injury, including proper work practices and use of equipment. On also how to recognize musculoskeletal disorders and their early indications. The advantage of addressing early indications of MSDs before serious injury has developed. And the nursing home's procedures for reporting work-related injuries and illnesses as required by OSHA's injury and illness recording and reporting regulations, which is 29 CFR 1904. Training for charge nurses and supervisors. It should reinforce the safety program of facility, oversee reporting guidelines, and help assure the implementation of resident and task-specific ergonomic recommendations. For example, using a mechanical lift, because charge nurses and supervisors are likely to receive reports of injuries and are usually responsible for implementing the nursing home's work practices. They may need more detailed training than nursing assistants on methods for ensuring the use of proper work practices, like how to respond to injury reports and how to help other workers implement solutions. Training for designated program managers. Staff members who are responsible for planning and managing ergonomic efforts need training so they can identify ergonomic concerns and select appropriate solutions. These staff members should receive information and training that will allow them to identify potential problems related to physical activities in the workplace through observation, use of checklists, injury data analysis, or other analytical tools. Address problems by selecting proper equipment and work practices, help other workers implement solutions, and evaluate the effectiveness of their ergonomic efforts. So this is Appendix A as a nursing home case study. It's a Wyandotte County nursing home used a process that reflects many of the recommendations in these guidelines to address safety and health concerns and phase in its current program that entails no manual lifting of residents. First and foremost, Wyandotte's administrator provided strong commitment and support in addressing the home's problems. He also involved Wyandotte's workers in every phase of the effort. He talked to employees, learned about stressful parts of their jobs, and then found solutions. He and his employees identified existing and potential sources of injury at the home and worked to implement solutions. He trained employees each time the nursing home introduced new equipment. He continually checked new equipment, and he continues to evaluate the overall effectiveness of this safety and health effort. And Wyandotte's located up in Sandusky, Ohio. It's a 100-bed county-run facility that has served Wyandotte County in its present building for the past 28 years. It's divided into two sections to serve residents with different levels of need. The A wing, with 32 rooms, serves residents who are mostly ambulatory and require only a minimum help with daily living. And the B and C wings, with 32 double rooms and 4 private ones, residents receive care that range from extensive to total. The total. Wyandotte has 90 employees, 45 of whom are nursing assistants. This makes for a nursing staff of 2.5 hours for each resident per day. And I don't know what the standard is on that. Before Wyandotte implemented its ergonomics program, the home was experiencing problems that were a growing concern to both the county and Wyandotte's administrator. According to Wyandotte, workers' compensation costs averaged almost $140,000 from 1995 to 1997. The turnover rate among nursing assistants averaged over 55% during that same time period. This meant that of the 45 nursing assistants working at Wyandotte, an average 25 new ones had to be hired each year. Well, that should tell you something right there. That's a big red flag. Wyandotte's administrators began to look for more effective ways to address injuries among workers and the high turnover rate. A back injury suffered by a worker that cost Wyandotte $240,000 of workers' compensation expenses provided significant motivation to find a strategy that would work. As Wyandotte's administrator investigated that injury, he also examined other sources of potential industry within the home. In doing so, he learned that resident transfer and repositioning tasks presented high risks for injuries. He called on the Ohio Bureau of Workers' Compensation for help because he thought Wyandotte was following the best practices and people were still being injured. An OBWC ergonomist visited the home and told him that he had unrealistic expectations about his nursing staff's ability to manually lift and reposition residents. Wyandotte's administrator thought that he could better use his existing staff. After hearing about a no-lift policy and seeing an impressive demonstration of mechanical lifts at an industry conference, he began to consider setting up a program at Wyandotte. He became convinced that such a program would keep employees safer and help slow the turnover rate while ensuring safety and high-quality care for residents. Industry conference, it's one of the things I've stressed too. That's what you want to do. You want to be taught on a rub elbows with people in your own industry. He decided the best approach was to involve employees at every level in reducing injuries and slowing the turnover rate. More than 30 workers volunteered to examine the tasks of moving and repositioning residents. Wyandotte employees concluded that better body mechanics, the traditional method of lifting and transferring residents at most nursing homes, was not the answer. In fact, he and his staff determined there was no safe way to lift a resident other than with mechanical lifts. To determine what equipment would work best, Wyandotte tried out various pieces of equipment, evaluated each lift, and then decided what would be the most appropriate for Wyandotte's needs. Very interesting. They decided that manual concerns only were not going to solve the problem. So administrative controls were not going to solve this problem, they decided. And they were probably right. So equipment, which would be an engineering control, they're going to try that. Implementing solutions with recommendations from employees. Get that, recommendations from employees, huge. Wyandotte's administrator bought several portable mechanical lifts for the B and C wings. These involve portable sit-to-stand lifts, walk ambulating lifts, and total lifts. Nurses and assistants could move each of these from room to room as they work with individual residents. However, many of the staff remain unconvinced of the value of using equipment. In fact, initially, only the workers who had actually evaluated the lifts were using them. According to Wyandottes administrator, it was very difficult getting workers to overcome their insistence on doing things the old way. That's unfortunately part of being a human being. Because many workers said it took too long to use the mechanical lifts, one of the co-charged nurses decided to do a time study. She wanted to test how long it took to lift a resident manually compared to using a mechanical lift. The mechanical lift took about 5 minutes. Meanwhile, to perform the manual lift, a nursing assistant first had to find someone to help. This took 15 minutes. Thus, the time study showed that using the equipment actually saved time. One worker who admitted that she did not initially use the sit-to-stand lift because it was a hassle reconsidered her option after an outbreak of the flu reduced the number of staff members available for assistance. In her words, I was forced to use the lift. Awesome, it was just great. I was so sorry my fellow employees had to suffer with the flu bug to get me to use this contraption. Wyandottes administrator also wanted to replace the old hand crank beds at Wyandotte with electric beds. To do this, he also needed to find beds that would be used in the low bed system in place for many residents. There were not many options available, so I took this idea as an engineering background to a bed company and inquired about having beds designed to fit Wyandottes' needs. The bed manufacturer designed the new beds to lift from the floor to a height of about 30 inches in 20 seconds. In addition, these fast beds were designed so that residents would be less likely to slide to the foot of the bed as they were raised to a sitting position. As a result, residents would not need it to be repositioned. Also, the beds can be used with a gate belt, that's what it's called, for ambulatory residents to assist them from a sitting to a standing position. About 3 years after Wyandotte began its ergonomics efforts, the nursing home received a grant from the OBWC Division of Safety and Hygiene through an economic emphasis program to deal with cumulative trauma disorders. The grant enabled Wyandotte's administrator to purchase 58 fast electric beds, a turning point for the staff acceptance. When the first ceiling lifts were installed 7 months later, employees were ready to use them. One nursing assistant who'd been with Wyandotte for 19 years explained why she liked the new bed so much. We can quickly bring the bed up to our work height with a push of a button, and we can reposition a resident with ease without stooping or struggling. One nursing assistant who had been with Wyandotte for 19 years explained why she liked, I guess I said that. The final phase of Wyandotte's program began with the introduction of the ceiling lifts. Wyandotte's administrator evaluated several ceiling lift systems. Wyandotte chose a system with a motorized lift and a ceiling mounted track. Tracks were retrofitted into the room at a cost of about $12,000 for 2 double rooms and 1 bathroom. The first double room had a track that extended into the bathroom. However, newer systems used a transfer between the room and the bathroom, which simplified the system and reduced costs. As Wyandotte purchased and installed new equipment, the workers received training on how to use it, and guidelines for equipment were put into place. An LPN in-service director did the training. New employees learned how to use the devices and know where to go for further instruction or help. Eventually, most of the nursing assistants adapted to the mechanical lifts and refused to use any other lifting techniques. Good. Wyandottes administrator took a personal interest in ergonomic issues. To address high injury and turnover rates at Wyandotte, he remained committed to identifying and solving problems. For example, on one occasion, the staff said the lifts were not easy to roll on the floors in the B and C wings. To solve the problem, he experimented with different wheels that would roll more easily and turn in tight places with less effort. Finally, he worked with a manufacturer to find and buy better casters to suit the home's flooring. Again, most vendors will work with people. In fact, if you have an idea, something maybe they could possibly use. To start with, Wyandotte's administrator spent $150,000 to buy equipment. He later set aside another $130,000 to continue his efforts, grand totaling $280,000. Wyandotte has saved $55,000 annually in payroll costs, according to the administrator, because of reduced overtime and absenteeism. The home estimates savings of more than $125,000 in turnover costs. Meanwhile, workers' compensation costs have also fallen drastically. For example, after the program was implemented, workers' compensation costs declined from an average of $140,000 to an average of less than $4,000 a year. That's staggering. $136,000 a year saving in workers' compensation costs. From the time workers began to use the sit-stand lifts, which were among the first to be introduced at Wyandotte, the incidence of back injuries stopped. Once the fast beds were introduced, only 6 new hires were needed in the following year. Worker satisfaction has greatly increased. One nursing assistant who has spent most of her career working in nursing homes confessed to being sore and unhappy at Wyandotte before the lifts were introduced. After the innovations at the nursing home, she reported that she's no longer hurting. She concluded that I think my career is right here in the Wyandotte County nursing home till my time is due to retire comfortable. And if my time comes to be in a nursing home, I hope I get one like ours. Mechanical lifts have also helped return a sense of dignity to the residents. As one assistant put it, through the use of the mechanical lifts, the residents are able to wear normal clothing again, which improves their self-esteem and keeps them warmer. The wife of one totally independent resident who has been at Wyandotte for 8 years reports that because of her husband's size, he cannot help the nurses and assistants in moving him from place to place. Before the overhead electric lifts and electric beds were installed in his room, it took 3 and sometimes 4 nursing assistants to move him from the bed to his cart or to the toilet. He had numerous bruises from falling and dreaded being moved. With the lifts in place, the resident's wife reports that the staff can easily move him about to his chair and to the toilet. He cannot sit without help, but the sling gives him comfortable support and makes it possible to have some dignity. That does it for this ergonomics course. I hope you all learned something from it. And there's a lot in this course. And again, this is ergonomics. A lot in this course you're not going to get anywhere else. So I hope you paid attention and learned something from it, because you will definitely be putting it to use in your career. And good luck to you all.